The one that I think of the most that is a big, looming, angry herd of freshly regenerated mammoths is the fact that we've got this generational dichotomy. We've got this problem where we've got the generation only just ahead of me, probably with some amount of grey hair, who are finishing up. They're tired. They're tired of teaching and supervising and training anymore. They would like to give up their procedural skills, because that's the thing that really is burning for us, is that we're running out of the rural procedural teachers, supervisors, mentors, someone to hold your hand in the first 6 months when you first do the job. And so that's that later generation that we're slowly but surely running out of. The other generational issue that's a challenge from a supervising perspective is, as everyone knows, that the new generations of trainees that are coming want different things and have different expectations. And we could all throw our hands up and say, that's not how it's going to work, because we're still the boss. And it's, they'll walk, they'll go somewhere else. So how do we meld in our disappearing supervisors with some particularly set ways about how they do things? And how do we manage to massage and bring in the new generation who want to train differently, who want to work differently, who want to have a life and not be completely concentrated in medicine all the time? That's probably, I think, one of our bipartite very big threat. There's a supervisor sitting here in the middle thinking, how do I keep both of these things happy? I guess if I have to be able to get down to answering the genie's offer of one question, it would be to make general practice and rural generalist popular again, because somehow the backside has fallen out of interest in doing the hard things in medicine, which are proper generalist practice, undifferentiated patients, and working across a whole spectrum of things that we do every day for patients that haven't been filtered and rarefied and investigated to the nth degree before they come in the door. And to make things easier for people to get in and get through general practice training and RG training. And particularly for RGs, the challenge is that we need to also make sure that we've got good, easy access to the hospital posts that they need to get in and do as well. Oh, good question. Great question. I think we've always spent lots of time having to balance the many different roles that we've had across time. Even before we went to college-led training, it's a challenge, again, because certainly in the case of ACRRRM, we tend to, just for safety purposes, we tend to have it that at least the political components, so things that cover off on some of the MBS aspects, as well as the payroll tax issue, we would often tend to try and leave that to RDAA as the political wing that represents rural docs from either college, or no college at all for the ones that are RDAA members that aren't fellow. That makes it a little bit easier for us from that perspective, that we try and have it that the things that deeply, darkly, politically impact on rural docs have a separate wing. Makes it sound like a political organisation, the IRA, separate wing to look after the more political aspects of what we need to do. We still have to get in and add our voice when it comes to things like MBS reforms and how we are supposed to train people up, getting them ready for the sorts of roles that we think they're fit for, but then have some of those things eroded by MBS reforms that may not necessarily match what's happening in real life out in rural anyway, from our perspective. So supervisors being asked to do effectively more with less, I think that's the gist of what you're trying to say, and with that continuing and inexorable pressure that comes from all of the sectors, that everyone's looking at the people that are the supervisors to do their day job as well as their supervising job. Is that kind of where I'm at? Yes? All right, so I've got three more wishes. So we're still assuming that college-led training exists. Yeah? Hopefully, my fairy godparent wand is better than my crystal ball. I guess the first wish that I would have is that we get to make more effective use of all of the training that's already out there. That we can almost select from a menu of things. I've got a fairy godmother wand. We've got an easily accessible menu of things that everyone in a practice could sit down and learn from. It means that we are facilitating, we're not necessarily delivering every single bit of education for every registrar, junior doctor, intern, medical student in the practice. So we've got a menu of things that we can choose from and a number of different ways to deliver training on a particular aspect to lots of people. And it's not just the supervisors that have to do that. It should be the supervisors that make sure it gets done, though. That's one. Okay. Two. It'd be really lovely to be able to supervise from almost anywhere. I'm the product of the RBTS. I'm the product of the Pat Giddings show and supervision by Bruce Chater 20 years ago before the camera that's on my computer existed. I would dearly love to be able to have it that if I am, that me being president, for example, means that I can't still supervise my registrars back in the other side of the building from wherever the hell I am, getting them on a camera very smoothly and have it that it's easily acceptable by patients, easily acceptable by anyone else who says that may be a contravention of the patient privacy issues. And it's in such a clever and immersive way that it's almost like I'm sitting in a room with them. Notwithstanding the fact that this is a technology-enabled fairy god person wand, and I'm sitting there in my Apple Vision Pro visor like I'm in the room. Because sitting there listening to someone do something, sitting there on a bed watching them do something is not necessarily the best way of doing it. The grand poobah for me has always been, I would be much happier being a fly on the wall and see how things happen in my trainees practice, whether it's medical students or JDocs or Reggies or anaesthetics registrars for that matter. I would be much happier being a fly on the wall than being someone in the room that modifies behaviour. That's number two, hey? Okay. Number three. Ooh, can I, as my last wish, can I please have some really good, dynamic, automated feedback systems, a few of them. It's trying to multiply my choices. I want to see that when my registrars do well or badly in an exam, that I can get some feedback as to what they've done well or badly. What are the key areas? I don't want the questions. I just want to know how I get them ready for either the next assessment or counsel them on what went wrong with the last assessment. Similarly, as a very technology-enabled wand, I want to have it that there's this continuous interplay between what my registrars are seeing and doing and what I'm having to go through and pick up on what they're seeing and doing in a day. Stuff that's my responsibility to know that they're seeing enough breadth and they're doing it well enough, rather than having to go back and drill through a couple of times a week through random things of their files to see what they're up to, which they know about. I tell them from the outset that's what they've got to play with. I want more dynamic stuff. And I'm a rural generalist, so I want to be able to supervise my registrars in primary care as well as their hospital-based secondary care stuff very seamlessly. I want to have it that I can be here for 4 days a week and be up supervising them 1 day a week, and that's just normal functioning. Here endeth my wishes.